Okay, welcome. I'm your host, Celine Sagras with Henry Schein Orthodontics. I'm currently situated in California, in the Carlsbad, where Henry Schein Orthodontics is located. And I'm very pleased to introduce you to Dr. Ana María Cantor, who is located in Barcelona, Spain today. Dr. Ana María Cantor will show you how efficiently and effectively she can treat Class 3 malocclusion in adult cases and in mixed dentition patients. With unique tools and treatment strategy, Class 3 cases can be treated easily and without surgery. A little bit about Ana María Cantor. She obtained a dental degree in 1990 from Pontificia Javeriana University in Bogota, Colombia. She then continued her studies and completed the Orthodontics and Dentofacial Orthopedics postgraduate program at Uni C.I.E.O in Barcelona, Colombia in 1994. Dr. Cantor is the director of Clínica dental Odontokids in Malaga, Spain, and in addition to her private practice, she's a member of the American Association of Orthodontics, the World Federation of Orthodontics, the European Orthodontic Society, and the Sociedad Española de Ortodoncia. Welcome, Dr. Cantor, and thank you for being with us today. Thank you.
Thank you so much, Celine, for this kind introduction. And hello, everybody. I hope you and your families are safe and well. These are special times, and the coronavirus has changed most of our lives. But at the very least, it has given us a chance, an opportunity to value what is important and most precious in our life. Our loved ones, our health, to read books, to share time, to listen others, to learn, to meditate, and to help. The COVID virus, although limiting our normal routine, and leaves us with this big question: how shall we how shall we use this time? I hope you enjoy this webinar and it will be useful for all of you. The topic I want to share with you today is mixed dentition cases and severe Class 3 malocclusion and how treating these two challenges efficiently. Now, this is a patient with a severe Class 2. This patient has convex profile with a marked mentolabial groove. In fact, his upper lip looks or seems longer. In his dental intraoral pictures, we can confirm his Class 2, a severe Class 2. In fact, the lower incisors bite against the palatal mucosa, and the overjet and the overbite is a big problem for this boy. He has also some baby teeth. We start in this patient with a motion in the maxilla and a lower lingual arch. And after 4 months of treatment, we can see how the overjet and overbite had improved. These are the extraoral X-rays at this moment of the treatment. In this view, this lateral view, we can see how after 4 months of treatment, the permanent premolars and canine in the left side had erupted. Even the motion was placed in the temporary or baby teeth. This occurs because the baby teeth are the path or the guide for the permanent teeth. And this is the patient after 14 months of treatment, and you can see how the canines are in class 1. And after 16 months of treatment, the patient is ready to start the retraction in the anterior area. This retraction will be made putting our power chain from the hook between the lateral canine in this area to the second premolar. This is the patient after 20 months of treatment, and you can see how the overjet was corrected. The patient shows a molar and canine class 1 relationship. He has good overjet, overbite, good interdigitation between the maxilla and mandible. And these are the pictures before and after, when you can compare how the overjet was corrected. As I said you before, the lower incisors bite against the palatal mucosa. Now the overjet was corrected. The big, this big class 2, this severe was class 2 was efficiently corrected. Here, the extraoral pictures after 20 months of treatment, when you can see the profile, the beautiful smile arch of this boy, how the nasolabial angle, the relationship between the lips and the mentolabial group had improved. This is our patient before and after. You can compare the upper lip. In example, at the beginning, the upper lip seems longer. Now the patient has good balance in all his soft tissues, and as well the overjet and the dental relationship is better and was corrected, was efficiently corrected, and one possible surgical procedure was avoided in this patient, starting in mixed dentition and finishing when he has all his permanent teeth. Even the E-line in his profile is good, it's perfect in this patient. You can see in the panoramic X-ray the parallelism of the roots. In this slide, you can compare the initial panoramic X-ray and the final panoramic X-ray, and how the nasolabial angle and the profile had changed at this moment of the treatment. Remember that we swallow 70 times by hour if awake, or 10 times by hour if we are sleeping. I focus in this because at the beginning of the treatment, we recommend to the patient to some exercises and some therapies to treat the tongue, because the tongue in some cases could be our enemy, avoiding a good correction of the overjet, or producing treatment becomes the same at the beginning if we don't correct the tongue. This article from some doctors of Alberta tell that one of the major factors for a successful orthodontic treatment in a teenager's patients is the acceptance of the orthodontic procedures. And in this article, they compare the carrier motion appliance with the forceps, and they confirm that the carrier motion appliance appears more comfortable for the teenagers and has fewer negative comfort related side effects compared with the forceps. This is important because the teenagers are a group of patients that if you motivate or gave the instructions for this type of patient, the patients want to be in this team and want to achieve the objectives you are finding. You are trying to find. This is another patient in mixed dentition. This patient is Ruben. Ruben is a boy with as well with a class 2, big overjet, and important convex profile. These are his intraoral pictures. You can see his overjet, his full class 2, lack of space for one lateral incisor, upper lateral incisor. We start to see some important changes. We achieve a class 1, but we need more, a full super class 1. We continue with the motion after 7 months and the black line use of motion. We continue to achieve a super class 1, and this is our patient. The overbite had improved. The lateral incisor had erupted because now this tooth has enough space for to erupt, spaces between the upper incisors. All the time in mixed dentition, we use force 1 and for longer time to achieve as well an orthopedic effect, inviting the mandible to go forward. After 8 months, you can compare the overbite, the overjet, and the spaces between the anteriors are better to all the teeth. We continue for 1 year with this patient, all the time with 6 ounces, 1/4 of inches, which is force 1, Aslx force 1. At the beginning, after 10 months, and after 1 year of treatment. At this moment, we decide to debone our motion, and at the same day, we bone a transpalatal bar to maintain the position of the molar in this particular case. Sometimes, the majority of time is not necessary, but in this particular case, we want to maintain this molar in this position with this transpalatal bar. It's very important to keep the rotation of the molar, not only the class 1. The important thing with in the sagittal first philosophy is to achieve super class 1 platform, a good rotation of the molar, and at the same time correct this the worst or the more difficult part of our treatments at the beginning of the treatment, or in this first phase, which is the sagittal condition. This is the evolution of the profile of this patient at the beginning of the treatment, after 7 months, 8 months, and at the end of the treatment after 11 months of treatment. This patient needs 12 months of treatment to achieve this class 1 platform and this improving of his profile. And after this first phase, we will wait for a second phase with, when the patient will have all his permanent dentition. You can see the change of his mentolabial groove, and how the mandible was invited forward to improve not only his profile, but also the patient don't snore anymore. After 12 months of motion, you can see the changes in the overjet, in the overbite, in the canine relationship. This is at the beginning, at the end of the treatment, or at the end of this first phase. And here we can see a video showing the evolution of his profile. This is another patient in class 2. And this is another girl. This is another girl that has a severe class 2 as well. She has many problems of decay. She has a big class 2 molar and canine. As well, this girl breathes and sleep badly. She suffered an hyperactivity attention disorder, and we start with this patient as well. These are the occlusal views at the beginning of the treatment, and we plan for this patient use motion in the upper and lower lingual arch in the mandible. This lingual arch is very useful because at the same time we can use this lingual arch as anchorage. We use this appliance to maintain the leeway space. This is our motion and how we can use this molar to bear the elastics. I want to show you this picture to explain that the motion needs to be bonded, not in the middle of the crown of the canine. The motion, the anterior part of the motion, need to be bonded against the mesial face of the canine, treating to put and bond from the molar to the mesial part of the canine. After 7 months of treatment and after 8 months of motion, you can see diastemas between the upper anteriors. You can see as well how the overbite was corrected spontaneously because the motion moves to distal the uppers, the posterior area, but remember that we have the transeptal fibers, and this lead these spaces between the anteriors. And this is our patient before and after 8 months of treatment. After 8 months, you can see the change of our overjet. We overcorrect in this particular case. You can see here the left side with Aslx 3D braces to improve her smile. This is our patient and how her profile had improved at this moment. This is the comparison before of the profiles at the beginning, after 8 months of treatment and after 10 months of treatment. You can see the improvement of the balance of the angles of her profile. In this, you can see how with the Aslx 3D, she has better position of all her anterior teeth, where treating this patient slowly because she wants to improve and have a beautiful smile. The mother and the girl won't wait until a second phase. She hates these spaces, and we bond these braces to improve her smile and make happy this beautiful girl. In these x-rays, you can compare and see how the airway had improved with this treatment. At this moment, the patient sleep well, breathe well, and suddenly her problem of hyperactivity and disorder. As orthodontists, we can resolve many important problems of our kids, our patients, making the right diagnosis and the right even the mentolabial sulcus better and beautiful now than before. She has here a profile. Now she has good and balanced relationship in all her soft tissues. And it's well known that the lack of sleep results in worse effectiveness at school and produce many problems, not only in children but also in adults. Even the growing hormone is produced mainly at night. And we need to have in consideration all these problems and how we can work and act and help to resolve in our patients some different problems, not only orthodontics or dental problems. Dr. Atia has a beautiful article when he says and concludes that the use of a carrier motion appliance in patient in class 2 increase the total airway volume, and this is an important thing to have in consideration when you treat our patients. There are another different articles that confirm the importance of the airway and how to treat these patients to avoid sleep apnea or problems like snoring or attention deficit syndrome and hyperactivity syndrome. This is another class 3 patient in mixed dentition. This boy has a concave profile as well. He has a flat mentolabial groove. We treat this patient with a motion in the mandible. He has anterior crossbite and posterior crossbite as well. For this reason, we will start in this patient aligning at the beginning the uppers to have a better anchorage for this for the motion. And in the first month, only we align with a O14 wire and braces. On the second month, we put a short motion in the lowers and O14 by 25 wire in the upper arch. We go sagittal and transversal at the same time in this patient because remember this patient has a posterior crossbite. You can see in this occlusal view the appliance to go transversal, and at the same time in the lowers we put in the motion, a short motion from the first premolar to the molar, because this is a temporary canine, sorry, the canines are erupting at this moment. After 6 months of treatment, we start with a round wire in the lowers. After 15 months of treatment, 3 months of motion and 12 months of brackets is how our patient is. This is the evolution of his profile. You can see this flat mentolabial groove with this beautiful supramentales surcus. As well, the upper lip and nasolabial angle is better at this moment. You can see the comparison before and after the treatment. After 18 months of treatment, you can see how our patient has positive overjet. The transversal micrognatism or crossbite was corrected. He has beautiful overjet and overbite, and we try to overcorrect a little bit, leaving these canines in a little class 2 to avoid future problems for this class 3 patient. This patient has a small lateral in this case. And after 20 months of treatment, we finish our case efficiently, redirect the growing of this patient. You can see the comparison before and after, not only the profile, but also the dental speaking. If you see the midline as well was corrected. And this is the sagittal first philosophy that is also a must in the mixed dentition. And why is the reason? Because we recommend start in mixed dentition if you can, because mixed dentition treatment has many advantages like redirect route, prevent asymmetries, improve the airway, as you see before, avoid anterior fractures, improve the self-confidence in kids and prevent bullying, help to correct habits, prevent crowding and impactions, and prevent skeletal problems. When is the ideal range for treat these kids? 6 years late is the ideal age. And after, go transversal if you need to correct this or maintain this part, except in this class 3 patient when we need to go sagittal and transversal at the same time. Remember that the bones are the support of the soft tissues, at the same that when one patient lost eyeball and this is not replaced, the eye socket becomes smaller. It's the same with the mouth and with the face, the rest area of the face. If you extract teeth that are not necessary, you can diminish the size of the bones, losing support for the soft tissues. All of us will age, but the trick is to make it gracefully. If you extract or you make treatments without a good diagnosis, you can age your patients or make that your patients lose soft tissue support. We have a protocol, and the reason is that we need to achieve the same results in all the cases, and we need to achieve stable results. because we need reproducibility and reliability. This is the SLX brace, and the protocol with the SLX is the motion SLX braces, 014 wire, 014 by 25 wire, 017 by 25 wire, and 019 by 25 wire. The motion to achieve super class 1 platform, which is very important, not only class 1, remember, rotate very well the molar. After we, when we achieve this class 1 platform, we need to put a figurate ligature from the canine to the molar. We achieve alignment and leveling with the 014 wire. We close anterior diastemas with power chain from the lateral to lateral with this wire. We start the retraction in severe class 2, division 1, or in class 3 cases with 017 by 25 wire. If not, the ideal retraction is will be made with 019 by 25 wire, putting power chain from the hook between the lateral and canine to the second premolar. This is the SLX 3D brace, and the protocol changed a little bit because we use as well the motion. We bond the SLX 3D braces, and the difference is that in this type of braces we use only 3 types or 3 wires of 15 wire, 20 by 20 wire, and 19 by 25 wire. The same with the 014, 015, we align and level with this wire. We close the anterior diastemas with power chain, and with this wire we make the retraction and finish the treatment. These are the schema for this philosophy of treatment. The motion that spends more or less 2 or 4 months, and we use the 3 types of wires of 15, of 20 by 20, and 90 by 25 wire. This is I will start with 2 class 3 adult cases. This is a patient with a class 3 agenesis of lateral incisors, and you can see here his her profile. In this extraoral X-rays, you can confirm the agenesis of the lateral incisors. You can observe here a little shortening of the roots of these premolars. You can confirm here her concave profile, her crossbite. Against her profile, she has a concave profile. She don't like herself when she is smiling. Here are the extraoral X-rays, the intraoral pictures, where you can see here her crossbite, anterior crossbite. She has agenesis of the lateral incisors, missing lateral incisors. We need to give this patient some alternative to the surgical procedure that she rejected since the beginning. Also, she rejected any possibility of implants. We start in this patient with motion in the lower arch. At the same time, we bond braces in the maxilla because we want to improve and make protraction of this maxilla. Notice that we bond microstops meshal to the tubes in the uppers to make at the same time with the elastics protraction of the maxilla. We remove at this moment the motion and bond the braces in the lowers. We have spaces in this area, and we continue to improving the premaxilla of this patient with these microstops in meshal of the tubes. After 15 months of treatment is how our patient is. We make the retraction from the hook to the second premolar in the lower arch. We close the diastemas with power chain from the canine to the other canine. We will reconstruct this canine as laterals, and we polish the palatal cusp of this first premolar because we want this premolar works as canine. Continue with retraction in these pictures. We can see a good overjet and overbite, good interdigitation, and after 16 months of treatment, we finish this case. Now here the canines are being reconstructed, and we recontour the palatal cusp of this premolar. These are the extraoral pictures of this patient. She has now a better profile, better smile. She likes herself. You can see the comparison before and after from the concave profile to a good profile. The lips relationship is better now. Her smile, she doesn't have crossbite anymore. We use the canines as laterals. She doesn't need implants or surgery. We resolve this type of patient with only with the sagittal approaching with a 16 months in total treatment time. This patient remains stable after 18 months, after 24 months, and after 3 years of finishing the treatment. After 24 months, she has good interdigitation, and the secret of this stability of this treatment is that she has a very good interdigitation, good contact points, and the best retention is a good occlusion. After 36 months that we finish our treatment, is how our patient is. This is a video when you can see how our patient changed. The final x-rays. Here the superimposition cephalometric and cephalometric measures. You can see how the occlusal plane had changed, has a counterclockwise change, which is better to improve the profile of this patient. She feels better now and have self-confidence at this moment. This article was published in the Ortho magazine, if somebody wants to review it. This is another patient, class 3, treated in similar way of this the anterior patient. This is a boy, and you can see his profile. He has a concave profile, important crossbite. Also, you can see in this panoramic X-ray how this second molar is lost. And he has an extraction in the first upper molar. Her profile is a severe class 3 profile. You can see in the intraoral pictures, you can confirm the micrognatism, the posterior crossbite, the anterior crossbite. And we start in this patient with an invisible bacon retainer in the upper arch and a class 3 motion in the lower arch. He has anterior and posterior crossbite, lower crowding and lack of space from the upper incisors. He has a full class 3. After 3 months of motion is how our patient is. Here with Aslx 3D braces and round wire of 15 wire. This wire help us to align and give a better control of the torque and all the teeth. This is our patient 8 months after the treatment. You can see the comparison before and after. As well, at the same in the before the patient, you can see the microstop meshal to the tube to improve and to give a protraction effect in the maxilla. In this anterior slide, you can see how the occlusal plane has counterclockwise change. It's important. It's very important for the width appraisal. This change of the change of the occlusal plane. This counterclockwise change. Look at the change in this overjet. We put a soft, very soft coil spring to open the space for this lower incisor, which is lingual. Remember, this is no surgery patient. After 15 months of treatment is how our patient is. After in the Wi-Fi is not working well, but after in the superimposition, I want to show you the change of the occlusal plane. This is our patient after 13 months of treatment. Now is a class 1 patient. We had correct the crossbite, the anterior crossbite, the posterior crossbite. Here you can see the canine that with a class 3 motion. Here, if you see the canine is a little bit extruded, it is important and it is not a problem. It's necessary to change the occlusal plane. With the lower motion, we achieve a bit extrusion of the canine and a small intrusion of the molar. It's very important to improve the width appraisal and change this occlusal plane. Let's to improve the profile and the facial aesthetic of our patient. Here with the braces in the lower arch, we continue with the microstop in the tube of the upper molar. We put bite ramps in the lower arch if it's necessary to avoid premature contacts. We put this very soft coil spring to make space for this incisor. In 10 months, we can observe and check how the crossbite had changed how his posterior crossbite had changed as well. And at this moment, as you, as I had telling before, our patient is a class 1 patient avoiding a surgical procedure. We are now only closing this space for this second molar, which was lost and extracted because has a infection and problem. We are now closing this space for this first premolar that the patient has lost at the beginning of the treatment. And this is a beautiful case that we can use as example to treat class 3 patients. In these occlusal views, we can see how the alignment was achieved, how this space is starting to be closing totally. This is the wisdom teeth, and we use and move this molar back and close this space of this molar that was lost at the beginning, since the beginning of the treatment. These arrows show you these sidekicks that are special elements to use elastics and helps to improve our posterior crossbite. This is the evolution of this profile of this patient, and you can see how, coming from a concave profile, we achieve a very good results with a good projection of the upper lip, beautiful mentolabial group, good relationship between the lips, and the patient is happy. In this comparison before and after, the patient is not finished yet, but we take profile X-ray to make a comparison the widths, and you can see how the widths have changed from the 12.6 to 3.8, and how the anterior crossbite had improved, and all the measurements are better in this patient. He now is happy because he has very, very good results, even the treatment is not finished, and he avoid surgical procedure that he rejected all the time. This is an article that of Dr. Magnamara and others, when he studied the width appraisal and how the motion appliance improve the width appraisal. This study is in a class 2 malocclusion patients, but this could be applied to the class 3 patients, as you see before. This is the superimposition of our patient, and you can see how the position of the lowers, the soft tissues, and the maximum mandible had improved at this moment. As well, the change of the occlusal plane, the final occlusal plane is in red, how the occlusal plane has changed, has a counterclockwise change, which is a key point to improve not only his profile, but also all the measurements in our cephalometric tracings. The comparison before and after. This is a second molar. This is a wisdom teeth. He has almost correct his posterior crossbite, has good overjet and overbite. He has now positive overjet, yes. This is another patient in class 3 with aligners. That is very useful in this specific time that we are passing now. We start with this patient with motion because she wants aligners, but if we use only aligners, we spend more time, and the motion is a very useful tool to diminish the time of aligners and to help to correct this sagittal problem at the beginning of the treatment. We put a lower class 3 motion in this patient to achieve a super class 1. We can observe the extrusion of the canines, which is something that we need to achieve good this change of the occlusal plane. That helps as well to improve the overbite in this particular case or in this type of patients with the aligners. And is an easy case if you have patients in class 3. I think that without motion it's impossible to have a good finishing or good treatment time with this type of patients. We continue with class 3 elastics during the day at night to help the treatment, and we finish our case at this moment.
Dr. Cantor, I have some questions here from the attendees. If you don't mind, I'm going to read some to you.
Okay, Celine.
The motion class 3 is good for class 3 open bite and deep bite question. Is it good for deep bite?
The question, yes, the motion, you can use the motion class 3 in open and in deep bite as well.
Can you use a mini screw for anchorage in the motion?
I don't use mini screws, but many doctors use mini screws as anchorage for the motion, mainly in the area of the retromolar area and the tuberosity of the maxilla, and it's very useful. I know that they had very good results with this type of approach.
How do you manage bilateral posterior scissors bite?
Can you repeat me, please, Celine?
Yeah. How do you manage bilateral posterior scissors bite?
Posterior scissors bite?
Yes.
Let me see. When we have this type of bite, we use sidekicks and elastics, short elastics, and the mostly of the times from the one appointment to another, this scissors bite had been corrected. And in easily way and without problem.
With class 2 motion, how do you choose between a lingual arch and or an Aslx on the lower arch?
What?
When in a class 2, with motion class 2, what made you decide to use a lingual arch at the for anchorage?
Okay. I use mainly lingual arch in mixed dentition patients to keep the leeway space, and but in mostly of the teenagers, And adults, I use an invisible retainer as anchorage.
Do you hold the arches with retainers after phase 1 treatment?
You use the what?
Do you use the retainer on the arch after phase 1? Like at the end of...
Sometimes I use, as you see, a palatal bar, or sometimes with anything. If you have a good class 1 platform and in the molar, even the baby teeth are a little flat, you can maintain this correction, and you can wait for a second phase.
Why do you use stops on the molar tube?
When do you stop? When what? The last part?
Why do you stop on the molar tube?
No, I don't understand the question of the...
There are some in Spanish. So, hola, doctora Cantor. ¿Algún paciente clase 2 y 3 de los tratados presentó síntomas o dolor en la ATM durante el tratamiento?
Okay. No, any patient has reported pain in the temporal in the TMJ during the treatment, because in class 3 patients, because the condyle don't move back. The condyle and all the occlusal plane and all the mandible rotate, and the condyle go down and rotate and have better position in the glenoid cavity. Any patient reports pain in this type of treatment, less in class 2. In class 2, the patient improve, and if the patient has clicking or pain, the patient feel better, and many clickings disappear with this type of treatment.
When the care application is made to the premolar teeth before the root development is completed, does the problem occur in the roots?
Can you repeat this? I can hear you well.
When the carrier application is made to the premolar teeth before the root's development is completed, does the problem occur in the root? I'm not sure I understand very well that question. Sorry.
If the question is if the roots has a bit of resorption, or the temporary teeth, impermanent teeth?
It wasn't very clear. How do you? No, I think we did that one already. How safe these issues can interpret?
In these issues. Okay. To bond the motion in the deciduous in temporary canines, an example, you need 2/3 of the root to bond this appliance, and you can move and use safely this tool without any problems.
Why do you figure 8 initially? When you with the figure 8?
Why? Because we want to maintain the correction done, and if you put this figure 8 ligature under the wire, you can keep this in this position while you are aligning and leveling the teeth with the braces.
Why are stops used throughout the initial wires, both anterior and posterior?
Both anterior and posterior. What?
Outwire stops.
The stops wires. The stop.
Why are you using at the initial wires? You're using stops. You know.
Yes, I use in class 3 stops because I want to make like an effect to improve the premaxilla and protract a little bit of protraction of all the maxilla with this type of microstops. If we put these microstops measured to the tube of the first molars, when you put the elastics in the uppers, all the arch is moving forward as an effect of this force of the elastics in class 3 motion.
What do you do when the lower cuspid presents mobility in class 3 motion?
It's not a problem because sometimes we observe a little bit of mobility and extrusion. And when we bond the braces and we are with the first or second wire, this is not a problem and this is resolved. It's a normal situation because the periodontal ligament is produce this type of situation for the movement in this treatment, in this part of the treatment.
Doctora, en pacientes clase 2 con mordida abierta anterior, ¿cómo consigue que no se aumenta la mordida abierta?
¿Que no sé qué?
Doctora, en paciente clase 2 con mordida abierta anterior, ¿cómo consigue que no se aumenta la mordida abierta?
La mordida abierta, the open bite is not improved with the motion because all the maxilla and is moving, the posterior area is moving back, and the overjet improve, and the tongue has a better position, a better space in the palatal area. And it's important to have and to do a big diagnosis at the beginning of the treatment because mostly of the open bites are produced for incorrect position of the tongue, not only at the rest, but also in swallowing and all the time. We recommend some exercise and therapies for our patients, and at the same time with the orthodontic treatment, we make an re-education of this tongue. But the open bite improve with this with the motion.
So I understand the posterior stops on the molars. Why do you add stops on the anterior teeth in class 3 cases?
The anterior, the microstops, if you are talking about microstops in the anteriors, is because you need to all the time we put microstops in the anteriors to avoid that the wire go from the one side to another side, because that happens in self-ligating braces. And this I put these microstops in the posterior area with the anterior for in my practice all the time. We put these microstops in the anteriors as well. Probably are not necessary when we put in the posteriors, but we put in the anteriors as well.
When the premolar's root formation is not completely formed and you use class 3, does it affect the root formation or cause root stunting?
Never, because it's a so physiological movement, and all the is a very this is an appliance that is very protecting all the tissues, and is not dangerous for this formation of closing of the roots of the premolars. I never seen a shortening of the roots, and I had used this appliance maybe 15 years ago.
Please discuss the timing of posterior crossbites first, or class 2 or class 3 motion use first.
Can you repeat me, Celine?
Please discuss the timing of posterior crossbite first, or class 2 or class 3 motion use. I think it's, why do you do the crossbite maybe after the class 2 or the crossbite at the same time as the class 3?
We treat and correct the sagittal aspect of our patients at the beginning, first than the transversal, because the worst and the more difficult part of correct our patient is the sagittal problem. And if we correct sagittal first, we can use the transversal correction after to maintain as well this sagittal correction. The exception that I made is in our class 3 patient in mixed dentition. In this case, I use and I make transversal and sagittal at the same time.
Thank you, Dr. Carrier. Thank you for that great presentation and sharing your expertise with everyone here. And thank you, everyone, for coming and joining Dr. Carrier in that presentation. And hopefully everybody stays home and safe and safe.
Cantor.
Thank you very much. Thank you.
Okay, Celine, thank you.